Great. Hello, everyone, and welcome to the webinar on vaccine reluctance among older adults with a history of trauma. Welcome to our subgrantees, the aging service providers, the esteemed speakers, and the 600 people who registered to join us today. I'm Shelley Rude-Wernick, Managing Director of the Jewish Federations of North America's Center on Aging and Trauma, a project of the Holocaust Survivor Initiative. Over the years, we've learned from the experiences of Holocaust survivors that trauma is at the root of many current responses to situations and environments. Trauma is a risk factor for access to services, and accessing the COVID-19 vaccine is no exception. After overseeing the funding of hundreds of person-centered trauma-informed projects in 21 states, and speaking with more than 24 leaders of minority and prominent aging groups, and sharing our work at national conferences, we've learned that the person-centered trauma-informed approach can be very helpful to older adults who have yet to receive the vaccine. The Jewish Federation's Center on Aging and Trauma looks at the impact of trauma on older adults and their family caregivers and proposes solutions using the person-centered trauma-informed approach. We're always looking for others to connect with us, others who share this goal, such as service providers and funders, so please reach out if you want to follow up. And at this time, I'm pleased to introduce Leah Miller, Associate Director for the Center on Aging and Trauma, to lead our webinar. Thank you, Leah.
Thanks, Shelley. Next slide, Abby. So my name is Leah Miller, and as Shelley said, I'm the Associate Director at the Center on Aging and Trauma at JFNA. So during this webinar, we're going to hear presenters give an overview of how the history of trauma can impact older adults as they age, also how the impact can contribute to the hesitancy among diverse populations of older adults in getting the COVID-19 and other vaccinations. We'll also hear from experts on strategies on how to ensure older adults have the information they need that's in a person-centered trauma-informed support to make decisions about their health. So some housekeeping is this webinar is being recorded, and we will circulate the PowerPoint and the recording after the webinar. And we ask that you put your questions in the QA box at the bottom of the screen, and we will definitely get to them by the end of the call. And so with that, Abby, next slide, please. So we are very fortunate today to have many esteemed speakers. We've given you their bios in the webinar invite, and so I encourage you to look at their backgrounds there. Next slide, please. So what is trauma? There's not one definition of trauma. SAMHSA's definition is an individual trauma is a result of an event that presents physical or emotional harm, and it has lasting adverse effects on the individual's functioning and well-being. And so triggers are a sound, smell, touch, taste, feeling, or circumstance that reminds the individual of the past trauma. It can elicit a fight or flight or freeze response. And regarding the pandemic, there's lots of examples of triggers, between social isolation and being separated from support systems to getting asked for documentation by officials can also be triggering. Medical testing, needles, also being herded into large stadiums or medical settings, or being called by a number when really you're just trying to get the next person in line. These all can be triggering. I think the most alarming thing to me to learn when I started working at the Center on Aging and Trauma is that 90% of older adults have a history of trauma. 90%. So that could be someone who's been through domestic violence, it could be a car accident, it could be due to political persecution, etc. Next slide, please. So trauma and health are linked, and the exposure to trauma can lead to lung disease, can lead to anxiety, depression, and I was surprised to learn that it even can lead to dementia and sleep disorders as well. Here's a broad list of different conditions. Next slide, please. So trauma impacts individuals of all ages and can evolve over time, the impacts. So the symptoms can evolve after a long symptom-free period. Maybe somebody had it nicely packed away in a box and have figured out coping mechanisms, And as they age, there could be a trigger that reemerges the symptoms. Also, it can emerge for the first time in older adulthood, maybe decades after the exposure, or it can be more extreme than had previously been experienced. Maybe you've met an older adult who all they want to do is talk about their past trauma and keep reliving it every single day and talk about it. And others don't want to talk about it at all. So really just parts of the aging process and the changes can be triggering as well. So maybe changes in familial roles. So maybe somebody was the decision maker or the caregiver, and now that they're older, their roles have changed and how they see themselves changes. Or if you're like me and you define yourself by your career, retirement could be triggering. Or maybe just work was a distraction away from the trauma. Emergence of health problems such as hearing loss or vision loss or loss of mobility, those may have been things that has saved your life before, and now you may not have control. Loss of independence, loss of control is always a hard one. Or if you lose a loved one, it could be that your whole financial status changes. Or if you have coping mechanisms like exercise or driving or walking or writing, those may be harder in older age as well. Next slide, please. So at the Center on Aging and Trauma, our main focus, we got a grant from the US Department of Health and Human Services Administration for Community Living 5 years ago to both expand the nation's capacity to provide person-centered trauma-informed care for Holocaust survivors, older adults with a history of trauma, and their family caregivers. And we do that through supporting grants at the local level, and we've done hundreds of programs across the United States and building the capacity of those who provide aging services like you. Next slide, please. So person-centered trauma-informed care is a holistic approach to service provision. And it promotes trust, dignity, and strength of empowerment of individuals by incorporating the knowledge of trauma into agency programs, policies, and procedures. So for example, with staff, think about how are you supporting staff from burnout or from secondary trauma. I think about my time on the front lines and how one day when I was working refugee resettlement, a common conversation was, what was the most creative way that you heard somebody tortured today? And it would have been good if someone had known that that could have been a sign that I needed help at that point. Next slide, please. Here's examples of what not to do. Can you imagine where you'd really want to go to the right if there was a sign that said where the sexually transmitted diseases are? So one thing is to make sure your signage is trauma informed, as well as the artwork on your walls reflects the individuals you're serving. Next slide, please. We base our person-centered trauma-informed care model off of SAMHSA's principles of trauma-informed care. And I just want to highlight that safety is really key, that both staff and clients feel physically and mentally, psychologically safe. Also, trustworthy and transparency, that if you're late, let your clients know, that sort of thing. Next slide, please. And I want to say, like, voice and choice are super important. Every program you create can be trauma informed, whether it's a socialization program where you give Ziploc bags so people can walk away with extra food and they know that it's not going to be wasted, or you eliminate the need for lines in giving food, because lines can also be triggering as well. Next slide, please. So with that, I would like to introduce our next speaker, who's a consultant, trainer, therapist, and educator, Myra Giberovich. Myra?
Thank you, Leah. Thank you. And to my fellow panelists, I feel privileged and honored to be presenting with you today. Next slide, please. I'd like to begin by talking a little bit about the interaction between Holocaust survivors' traumatic experiences and aging. And these are some key features. Their current losses and a decline in health may trigger their wartime memories and vulnerabilities during that period of time, resulting in grief, anxiety, depression, and sleeplessness. The developmental tasks of aging also play a role. As we go through life, there are certain developmental stages and tasks that we achieve. For older people, it's reflecting upon and re-examining their lives. and also dealing with emotional conflict, unresolved issues. Survivor guilt is an issue, also giving meaning to their survival. Cognitively, traumatic memories are more firmly embedded in the long term or secondary memory and more easily accessed. And psychologically, protective defenses or coping mechanisms such as repression are weakened, releasing traumatic memories to consciousness. There are also fewer distractions. Retired survivors, especially men, when they lose their role, they lose the structure, they lose the job that may have given them meaning and purpose, they then re-experience what I call the onslaught of their traumatic memories. And then there's the delayed onset post-traumatic stress disorder. Symptoms develop decades later. And then there are the environmental triggers or situations or events that are reminders of the original trauma. Next slide, please. And the COVID-19 vaccine is an example of an environmental trigger. And these are some of survivors' trauma-related concerns. Their loss of identity. Numbers were tattooed on survivors' arms and they weren't known by their names anymore. They were a statistic. And these tattoos were done with needles and no anesthetic. It was a painful process. I wish to add, though, that not all survivors had tattoos on their arms. There is also the mistrust of medical personnel who administer the vaccine, particularly doctors and nurses. During the war, doctors decided who would live and who would die when survivors arrived at a death camp. They also conducted heinous medical experiments together with nurses, and they supervised the killings in the gas chambers. Medical experiments were conducted on groups of people, such as twins, for example, and dwarfs, whereby people were injected with foreign substances, resulting in lifelong medical conditions and illnesses. Painful injections were given, blood was drawn. Camp prisoners were injected with drugs and carbon dioxide to test various methods of sterilization. And then there were the experiments to test drugs and treatments such as malaria, typhus, and tuberculosis. There's a mistrust of government bureaucracy and authority figures. The Holocaust was a state-sponsored genocide, and all levels of government and most of society were co-conspirators in mass murder. Next slide, please. What are survivors' reactions to the vaccines? They're not a homogeneous group, and the survivor community is diverse, with Jews from different backgrounds and experiences. In preparation for this webinar, I consulted with 4 social service agencies across Canada and learned that the majority of survivors that they provide services to got vaccinated. One agency contacted 1,200 survivors and found that most were resourceful in conducting their own research and scheduling their own appointments for the vaccine. These are some of the reasons given by survivors who have not been vaccinated. The vaccine rollout challenges in Canada, conflicting information about vaccines from local and international sources, health concerns such as pre-existing medical conditions, the lack of trust in countries who were producing a particular vaccine, their traumatic experiences during the Holocaust, and then their lives in post-war communist countries, and trust issues related to government institutions and healthcare providers. Next slide, please. So the theoretical framework that's used, as Leah discussed, is person-centered trauma-informed care, or an approach referred to as PCTI, and these are the main pillars: to give survivors a voice, choice, control, to help empower them, to collaborate with them, and to establish safety and trust. Next slide, please. So how do we then implement this theory into practice? And here are some trauma-informed strategies. It begins with a philosophy. It's a person-centered approach that places survivors, their values and preferences at the center of care. And it's important to have a resilience mindset, to view survivors as the directors of their lives, capable of making their own choices and decisions. These were the driving forces for them after the war as they immigrated to countries around the world, put down new roots, learned new languages and trades, and contributed to their communities. It's important to meet survivors where they're at, to give them a voice, to listen empathically, and to validate their concerns. And there may be a fusion of past and present. So to explore if their past traumatic experiences may be influencing their decision about getting a vaccine, and to inquire if they're open to making a different decision, a different choice. And if they're not, if they're vehemently opposed to having any information or discussing the vaccine, then we need to back off and respect their wishes. And we can invite them to collaborate with us and to explore ways that they can become informed decision makers from a place of safety, agency, and allowing in new information. Next slide, please. If survivors are open to it, and if they request information, we can provide information about the vaccine from public health sources, that it's available in different languages. After the information is provided, it helps to follow it up with a phone call to see if they have any questions. And some survivors access vaccine information from trusted experts within their community who speak their ethnic languages. And some survivors also find that having easy access to a vaccine may impact on their decision. It's important to give survivors permission to refuse the information we offer, and that's all about choice and control. Next slide, please. Some cautionary notes. To refrain from persuading survivors, let them know you're available to answer their questions, book an appointment, or arrange transportation. Some service providers may have their own bias about the vaccine, and some people have very strong thoughts and feelings about it, whether to get the vaccine or not. And it may impact survivors' decision whether they receive the vaccine or not, because they may ask their workers. So does your agency have a disclosure policy about whether staff share this personal information? And then also, it's important to distinguish between survivors' trauma-related concerns and their actual fear of needles. Dr. Anna Tadeo, who is a pharmacist and researcher at the University of Toronto, came up with the CARD system, the acronym for Comfort, Ask, Relax, and Distract on the actual day of the vaccine, that addresses people's fear of needles through pain management and coping strategies. Next slide, please. So in conclusion, it's important to determine the reason for vaccine hesitancy, because each issue will require a different strategy to address it. So the first one, if it's a trauma-related concerns about past experiences, then we can help them to distinguish between distinguish their past traumatic experiences from the present. And if it's information about the vaccine, here are some questions to consider. What sources of information are provided? How is the information being disseminated? And are service providers educated about the safety and benefits of the vaccine and the risks? Also the fear of needles, and I'm recommending the CARD system. Thank you.
Thank you so much, Myra. And next I'd like to introduce Orlene Grant.
Thank you so much, and it is a pleasure to be here today. I really would like to thank the Jewish Federation Center on Aging and Trauma for this opportunity, and to also be here with my fellow panelists. Next slide. One of the things when I was talking to Leah Miller about how to structure this presentation, we basically came up with starting from the very beginning. The Juanita C. Grant Foundation was founded in memory of my mother, Juanita C. Grant, who was a civil rights, civil activist and civic activist, along with her husband, Dr. Benjamin F. Grant, in Gary, Indiana, around the 1950s. It was a very challenging time But one of the things she did was really look out into the community to see what the needs were. And there was a lot going on in the 1950s. If you think about SAMHSA's 3 E's for trauma, the event itself, experiencing the event, and then the effects of the event, you can understand in the history of what she was going through at that time, how all those collective memories were coming together. So some of the things she was dealing with as a civil rights and civic activist was desegregating the hospitals in Gary, Indiana for African-American physicians. At that time, you could only admit African-Americans to a makeshift hospital that was set up in a very old hotel. The other one was in looking at the civic activities within Gary, Indiana. My mother was instrumental in co-founding the Gary chapter for Jack and Jill, and went on to do national work for the AKA sorority as a national secretary. Again, reaching out into the community, looking at the various things that needed to be done, and then able to create and move forward with that. The other one that she did was co-found the settlement house for the arrivals from the Jim Crow South. Again, this was a traumatic event for most people, leaving a sharecropper life, looking for opportunity and safety. The settlement house was created as a safe haven for people who were newly arriving in Gary, looking for work at the steel mills, to have a safe place before they decided, where they could have housing, how they could get employment. And the other two, I think we have the Gary chapter for Jack and Jill created activities for families, and having a fairly segregated city. These activities were safe activities for families to come together and have enriching programs for children. And then her outreach into the community on a national perspective as a national secretary for AKA, which has become more popular again with the election of Kamala Harris. Next slide. So looking at the timeline for the foundation, I purposely incorporated in Maryland because I had done some other work in the state and in Prince George's County, and knew there were a lot of needs that were not being met by the nonprofit world, and really decided this was an opportunity to make an impact in the community, to do true community engagement on the ground. The first 2 years of our existence, we did research with the board members, looking at census data, statistics, statistical reports, talking to government agencies, individuals, and doing budget analysis, and came up with the 50 plus, the older adult African-American population was just kind of falling through the donut hole. And as a result of that research, we came up with the programs of advocacy, but workforce development, looking at elder abuse and financial fraud, and also social isolation. So creating the Village Connector Experience program to reach out to older adults who are experiencing that. One of the things that is really remarkable about all the interactions that we were doing on a face-to-face basis was really working with a population that was varying in the age range up to the 80s and a little bit past, but about 72, 62 range between the years that we were able to do in community engagement before COVID-19. Predominantly 75% of those were African-American women who were experiencing socio-economic difficulty, especially with economic insecurity, and really balancing between paying the rent, paying the car note, buying medication, or buying food. Next slide. It was during COVID-19, we were conducting one of our elder abuse and financial fraud series just when the government shut down the country. And at that time, we were talking to individuals in senior community centers about their fears, their hesitancy. People were already spacing out, talking about what could be done, what were the precautions coming, what would be the remedy for this, even looking ahead as to what the vaccine might be. And that was pretty typical, looking at communities of color, also immigrant communities that may have not access to healthcare because they may have not been documented properly. And at that time, there was a lot of concerns as to whether or not they could come forward and receive treatment or really be engaged in how information was being rolled out. But COVID-19 also rose up, and we found that there were some surprising pockets of vaccine hesitancy. Police, you would think on the front line, firefighters, armed forces, those three armed branches of public service are running between 30 and 40%. Hospital staff, Johns Hopkins Hospital across the system, which is pretty broad, is running at 70%. And then you have the white evangelicals, southern states who have had a tradition of low vaccine, and also health inequities. And then the immigrant population who basically really needed correct messaging and also information that was tailored. And then athletes. On the front line, role models, very surprising that there was some very well-known vaccine hesitancy in that particular group. Next slide. And so you look at remembering SAMHSA's 3 E's of trauma. You look at the experience of older African Americans and the history of what has been experienced by this group. And you can understand that there's a collective awareness, a collective almost DNA response to the history and current level of trauma that is occurring on a day-to-day basis. So these are some of the major historic and current events that have happened beginning in 1619 with the arrival of the first Africans in bondage to the Juneteenth just recently being acknowledged, the Jim Crow era, which was long-standing and had long-term effects upon the psyche of African Americans. And then the most recent US public health experiment, Tuskegee experiment, which ended basically in 1974. And that's a very recent number. It's this one where most people can remember what they were doing in the 70s, but really very much unaware as to what that experiment was about. And then the collective raising of consciousness on Black Wall Street massacre that occurred on June 1st. And then the AIDS epidemic and the rumors about the CIA targeting gay African-American men. And coming down to the most recent Jim Crow 2.0, as a result of looking at all the restriction of services, inequities in the healthcare system, the economic system, and then the recent rush to restrict voting rights. Next slide, please. Dr. Alma Stewart, who is the first African-American president for the American Psychiatric Association, stated recently that racist confrontation really motivates the fight and flight response. And in the fight and flight response, we know that there are cortisol levels are elevated at that time. I think this statement is significant because if you understand the sense of feeling fight or flight on an ongoing basis, on a daily basis in your life, you have these high cortisol levels surging through your body. And that has a lot of impact as to how you perceive the world, how you're feeling, the level of stress that you're under, and considerable impact upon your long-term health. Next slide. And so when you come down to, there are current and microaggressions. The murder of George Floyd, which was witnessed by the world. And then you have daily affronts to your dignity, 1,000 slights, and disrespect to older Americans, not respecting their age or not respecting their presence. And then overwhelming fear of the police. So those are some of the daily flights that you would have in addition to just trying to exist in the world. So the inequities of all of these coming together. Next slide. So in looking at this, one of the things you can do is really look how you can do an intervention to avoid triggering these. That is empowering the individual with respect and dignity, giving them a sense of safety, not confronting them. Look at your body posture, look at your tone of voice, look at the space, the personal space, respecting age, respect your elders is the old saying, ensure the dignity as you would yourself, and then by all means recognizing their identity. And so the strategies would be community engagement, go to trusted members within the community to do the messaging, have messaging tailored to that particular group and the nuances within that group, and identify within that who can carry that message in the trenches, door to door, such as Mayor Bowser and Dr. Fauci are doing in Washington, D.C. Next slide. And so in conclusion, we're going to continue this journey together, hand in hand. Next slide. And I thank you for this time for the presentation.
Thank you so much, Orlene. Next, we have Rafael Martinez.
Hello, I am grateful to be here along with the rest of these panelists as they are showing their expertise and they're sharing their knowledge with us on this day. And so I'd like to talk about the LGBTQ community and aging and how there are going to be very specific and also it's a both and of both very specific and very broad understandings of like certain barriers that could lead to preventing getting the vaccine hesitancy, and ways to kind of address them. I am more of an orator, so I don't really have many slides. It's more about the conversation and just sharing the knowledge that I had through my time working at Callan Lord Community Health Center. Callan Lord Community Health Center is one of the, if not the first LGBTQ community health center in the United States. It was started in the 80s, 85 with the surgence of HIV/AIDS. And a lot of what I have to share, I want to first begin with the understanding that this thing called intersectionality, and this thing called intersectionality has been talked about since Kimberly Crenshaw kind of first coined the term in 1986, with this understanding that people are multifaceted. People hold more than one identity. For example, there are LGBTQ Black people, there are LGBTQ Latinx people, there are LGBTQ Jewish people. We come in all kinds of shapes and sizes in this way. And so many of the historical and systemic experiences with trauma, right, that have even been shared in these previous presentations by both Myra and Orlene, we'll also have people who identify as LGBTQ that experience them as well. And it's kind of with this understanding that we as clinicians get to come into the space with our clients and meet them with the fullness of their experience, and understanding that there are ways in which the specific LGBTQ aging experience will show up in that kind of, in that broader sense, with and how relevant that is, because what we're talking about ultimately is ways in which the systems that we engage in, this one in particular, the health systems that we engage in, often can replicate certain harms, right? And how we as workers engage with them. How can we build that kind of trusting, consent-driven work with the people and communities that we serve? Because ultimately it is that sense of meeting them where they're at that leads to the alliance, in kind of therapeutic terms, the alliance with our clients, the alliance with our communities, and how that works with addressing some of these traumatic experiences that can affect vaccine hesitancy. I often think about how with the LGBTQ aging population, many of them have survived through the HIV/AIDS crisis and pandemic and epidemic, and how an aspect of this, right, an aspect of treating HIV/AIDS in the beginning was to take medications that caused a lot of physical harm. When I think about that, I think about AZT. I think about how AZT really ravaged the body in order to fight the virus. And so I think about this, and I think about the language around taking the vaccine and how the vaccine can often cause kind of the certain symptoms, and being able to work with our clients in this way that isn't denying that this is also a real possibility. We don't want to create a fantasy for our clients. We actually want to meet them in a very transparent and open way. We're not sugarcoating it, rather just speaking plainly and understanding that this is also a part of the experience, and how that experience might actually be triggering for folks who have witnessed their fellow community members go through a certain medication regimen that caused physical reactions. I also think about how for medical facilities often do not have gender neutral or gender inclusive languages for folks who are intersex or trans, that creating documentation that can also be inclusive, because being misgendered or even being called a legal name rather than their preferred name can often cause a traumatic response. And so if there are these barriers even to this, we have to be able to work with our clients and also work with our organizations to create more inclusive spaces where we can talk about using preferred names, using proper pronouns as folks work on getting access to vaccines. And also the hesitancy there of working within medical institutions that largely often ignore LGBTQ people and their specific needs. I also often think about how family has the possibility of looking quite different for LGBT people and LGBT aging people. Oftentimes the price of coming out is ostracization, oftentimes from biological family. And so one of the amazing strengths and places of resilience that the LGBTQ community has is the ability to create family that isn't necessarily biological, right? It creates partnerships and community memberships and friendships that we as clinicians get to engage with them with that when exploring who they can be supported by or who they're getting the vaccine for, while also understanding that the aspect of consent and choice is crucial. And I think Myra and Orleen have also kind of named this, the idea that we get to not pressure, not push, but to come from a knowledge based, and also to let them know that it is ultimately their choice and their place of consent to engage with this. That is kind of that form of empowerment. And also the understanding that we can create that affirming space with our clients when they are showing up with traumatic experiences, traumatic symptoms, of that kind of affirming space, of that understanding that these systems have played out in these ways that they know, in the ways that they then share with us, and we can meet them there. And ultimately, kind of the understanding is that we can then create what is often kind of noted as the corrective emotional experience of creating that affirming space, that self-driven space, that space that comes from that empowered sense, that they can ultimately choose what's best for them with the knowledge that we can offer them. Thank you.
Raphael, thank you so much for presenting. Next, I'd like to call on Shannon Patrick. Shannon?
Thank you so much. I'd also just like to thank you for the opportunity to speak today with such esteemed speakers. I've really enjoyed everybody's presentations to this point. My name is Shannon Patrick. I'm a program director with MHP Salud. And for those of you who are unfamiliar with our organization, we're a national nonprofit that promotes the community health worker profession nationally as a culturally appropriate strategy to improve health. And we also implement community health worker programs to empower underserved Latino communities. And we've been doing this work for over 38 years. We recently received funding from the Administration for Community Living as a technical assistance resource center focusing on strengthening aging services for older Hispanic adults. Next slide. So the Hispanic and Latinx community includes people with origins from well over 30 countries. So the examples I'm going to provide today aren't necessarily representative of all of them, but I would like to highlight a few historical events that have had a traumatic effect on the larger communities that may affect older adults' decision-making to get vaccinated for COVID-19. So the first is forced and coerced sterilizations. In Puerto Rico, from the 30s to the 70s, about 1/3 of the island's women were sterilized under population control policies over concerns of overpopulation and high rates of poverty. It became so common on the island that it's referred to as la operación, or the operation, simply put, and people know what they're referring to. Puerto Rican women have also been the unconsenting subjects of medical experimentation of birth control methods, including the first large-scale clinical trial for the pill in 1956. And in another instance, women were also told that tubal ligation was the most effective method of birth control without evidence to support that at the time, which allowed for experimentation with that surgery. So it's understandable why Puerto Ricans often feel that they're being seen as the guinea pigs for research studies, and there's hesitancy associated with that. Eugenics laws were also developed in the United States in response to large amounts of Mexicans immigrating to the United States. These laws allowed for forced sterilizations. Women were institutionalized in correctional facilities or asylums, and this often happened to younger women without justification. And it started as early as the 1940s and continued through the 70s. And we still hear about cases as recent as 2006 to 2010, where 100 mostly Black and Hispanic women were sterilized without their consent in a California prison. Forced sterilizations for Hispanic women is a particularly traumatic experience because they often identify strongly with being a mother, and the family is valued above all else in Hispanic culture. And once the possibility of being a mother is taken away, it can be really hard to cope with. So many of these women are older adults now and remember this coercive or forced procedure, and we must think about the mistrust in government and medical institutions resulting from these experiences. And all of this can affect their decision to get vaccinated. There's a mistrust in the government, which is sponsoring the cost of the vaccine oftentimes, and they promoted a quick turnaround for the development of the vaccine. Survivors might think that this vaccine is just another tool to cause harm to the community or feel that they're being experimented on. Someone who experienced a coerced sterilization after signing forms in a rushed situation where they weren't explained properly what they were signing up for might be hesitant to sign these consent forms for COVID-19 vaccine authorization. And then finally, this was also mentioned previously, but language barriers and health literacy can contribute to hesitancy because although information might be translated into Spanish, it's often in a reading level that's not representative of the older adult Hispanic population. And so people might be hesitant about what they're signing up for. Secondly, immigration-related trauma can be felt across many Latino communities. Trauma can occur at any point throughout the immigration journey, and it can increase the risk of experiencing PTSD. Experiences as immigrants here in the US may lead to vaccine hesitancy, especially for somebody who is concerned about their legal status or who is undocumented. So there's a collective trauma around the fear associated with deportation and many feel that getting vaccinated will bring attention to themselves or their family as immigrants. Having to provide information or identification can be traumatic. And we also have heard people say that they're concerned that they'll have to pay the government back after. So although the vaccine is free now, they'll have to pay it back later, and there's fear around that. Older Latinos often live with family members of multiple generations, and there may be mixed status individuals in the same household. And anything that they perceive will put them at risk for deportation is a scary experience, right? And it could be triggering. Next slide. So quickly, I'd like to share some information about how community health workers can address vaccine hesitancy in a patient-centered, trauma-informed way. Here is a definition provided by the American Public Health Association of community health worker, but I'll go ahead and summarize. Next slide. That a community health worker is a trusted member of the community who empowers their peers through education and connections to health and social resources. Next slide. So there are some CHW core competencies that explain the work that they do. I've selected some of these competencies that are related to patient-centered, trauma-informed care and addressing vaccine hesitancy for the purposes of this presentation. The first is relationship building and establishing trust. So CHWs are from the communities they serve. They look like the community. They speak the language of the community. They understand some of these barriers and experiences that the community has. They show that they care. They actively listen when they're communicating with patients. And older adults often are more likely to open up about their traumatic experience and share concerns related to vaccines if they're talking with someone they trust. Systems navigation and care coordination. They can help people get a vaccine appointment, but they also listen to their other concerns and needs and can provide resources and referrals to other social needs and follow up on that. They're not only concerned about getting people vaccinated. They can also attend vaccine appointments with individuals who are fearful of attending the appointment, and they can provide support to anybody who's fearful of navigating our healthcare system. Cultural mediation, excuse me. So community health workers help explain how our vaccine system operates, why it was approved so quickly, if there's hesitancy around that. They can also help vaccine clinics and organizations understand some of these unique concerns and perspectives that our older Latinos have about getting vaccinated. They empower the communities through listening and validating their concerns. They also advocate for individuals' needs. They have a loyalty to the community they serve, which is unique for community health workers. They're not only loyal to their organizations, they also have a loyalty to the community, and they never push vaccines on anyone. This was also mentioned by other presenters. And finally, culturally appropriate health education and information. They can translate medical jargon into something that's understandable for older adults. They can use storytelling and shared cultural values to do this. And they also never provide incorrect information. If they don't know the answer to something, they can always get back to somebody. And so CHWs, by definition, are patient-centered. They can receive special training to provide trauma-informed care, and supervision by a social worker or having social workers on the care team can also help CHWs when working with an individual with significant trauma. And they can be that bridge to care for many older Hispanic adults who would not normally seek or access mental health services. Next slide. And then lastly, I'd like to just run through a technique that can be used by community health workers. It's called the CASE approach, and it's created to address vaccine hesitancy. It was developed by Allison Tepper-Singer, the president of the Autism Science Foundation. And these 4 steps can be used to address vaccine hesitancy concerns. The first is corroborate. The second is to share something about you and share the science, and then explain what can be done. And so I'm going to go through a quick example, and then I'll pass it back to Leah. So if you're doing outreach, a community health worker met a woman named Lolita. She's a Mexican-American, 75-year-old woman who had a coerced sterilization when she was younger, and she's concerned about getting the vaccine. She feels like it's a scam. And she's heard that it can cause infertility, and she doesn't want to participate because she's misunderstanding some of this information. And so the CHW can ask more about that and support her concerns, validate her concerns through corroboration. They might say something like, I understand your concern, and a lot of ugly things have happened in our community, and being cautious about getting the vaccine is smart. I would never put anything in my body that I didn't fully understand. The second, they could say, I also had similar concerns, so I did some research about this before getting vaccinated myself. Then they could share the science, summarize the science in a way that's understandable for the older adult, and then finally explain that, you know, it's ultimately your decision. However, it can be more, you know, dangerous for an older adult not to be vaccinated because they are at higher risk for complications, right? And just supporting that older adult and the decision that they make, and potentially going to an appointment with them if they choose. And then finally, I just like to say that CHWs do this work with support from their organizations and supervisors, and getting proper training on vaccine and how it works, and common myths and misconceptions. And with that, I'd like to thank you so much, and I'll pass it back to Leah.
Thank you, Shannon. Actually, I would like to thank all of our speakers right now, and you're welcome to show your faces. We really appreciate you sharing the triggers of the populations that you serve, as well as ways to address their concerns, the older adults' concerns, in a person-centered, trauma-informed way. So I want to thank you for that. I encourage all of the participants to ask their questions in the QA box at the bottom of the screen. We cannot unmute the lines because I think it would be chaos with 300 participants. So please do put your questions in the question box, and we will get to all of them. This session has been recorded, and we look forward to sharing it in the PowerPoints after this webinar. And I also wanted to let you know that we have a very brief evaluation that we would love your feedback on as we continue to try to educate the Aging Service Network, and we always are hoping to improve. So if you could answer those few questions after the webinar, that would also be very helpful. So with that, and also JFNA subgrantees, we will show you the secret word near the end of the webinar, and that way you can prove your participation and be compliant with the grant. So with that, I would like to introduce my colleague, Abby Neft, who's gonna moderate the QA session. Abby.
Hi, everyone. I'm very glad you attended. We have a few questions. First of all, for Raphael, this question was, some aspects of intersectionality, example, sexual orientation, can be quote unquote hid, while others, examples, gender, race, are overt. How can we practice cultural humility when we may not even know all possible cultures that exist within one individual?
That's actually a really amazing question. And one thing I'd also really love to kind of introduce as a interesting complication of that question too is also gender. Can also be one of those things that doesn't necessarily play out with how we look at all times too. So one way like I have taken to think about like, how do we look at all these like multiple identities, perhaps ones that are not easily discernible to our eye, is simply to ask that kind of open question of that sharing of like, what identities do you, would you like to share in this space today? What identities do you, like, what identities have impacted you in the way you live or in how the world treats you? In this way, like it can both allow that space of openness and also the understanding that our identity, like the systems that we live in also affect us with the identities that we hold. So it'll allow the clinician or the organization to kind of get that understanding, not only of the person and their identity, but also how they walk and move through the world and how it's affected by that.
Great, thank you so much. I am going to share all of the questions that are asked in the chat box, just so everyone has more of an idea about what is happening. So the next individual question is for Myra. This question reads, regarding the pockets of vaccine hesitancy with groups of frontline workers and medical professionals, is this something that is consistent throughout nationwide?
Please repeat that.
Yeah, absolutely. I will put it in the chat as well. This says, regarding the pockets of vaccine hesitancy with groups of frontline workers and medical professionals, excuse me, this is for Orlean, my apologies. Is this consistent throughout nationwide?
Thank you. The pockets, you have some systems like Johns Hopkins, which has spread throughout the country. I mean, you can see it's grown by leaps and bounds, just as the Mayo Clinic has. So that statistic was system-wide. The armed forces is systems-wide, as well as the police have different pockets. The one I was quoting was the state troopers in Virginia. But hospital workers across the board have a fairly low level of immunizations compared to what you would expect healthcare professionals who are on the front line to more or less embrace having the vaccine, because they are most at risk for for the virus contagion, as well as police officers. But you do have pockets of it. I do know in Florida, some statistics of the firefighters in Florida, that level of compliance is a little bit lower than the rest of the country, but then Florida as a whole, in some pockets, have low immunization rates, as well as the Deep South has low immunization rates. So some of it is system-wide and some of it is local-based.
Thank you so much, Orlean. The next question is for Myra and the other speakers. Does Myra and the other speakers have any thoughts on addressing vaccine hesitancy, specifically through Holocaust survivors from the former Soviet Union?
Yeah, survivors from the former Soviet Union experienced oppression after the Holocaust as well. And it relates to the mistrust of government bureaucracy. And that plays a role, you know, not trusting the information that, you know, that our government may be providing. So it's certainly government, you know, governments certainly do play a role in hesitancy for survivors of the former Soviet Union.
Great, thank you so much, Myra, for your answer. We have a few more questions here. One of the question is, how do we guide clients who ask us for their opinions and whether or not to get the vaccine? This is from a social worker who says that she's not informed of the medical aspects, but the clients trust us in their opinions.
Yeah, I'd like to respond to that. The fact that they trust us, you know, may influence their decision. And so one way that we can respond to it is by reframing it. In other words, are you asking me the question because you're not sure whether to get the vaccine or not? And then to have a conversation about that. What is your hesitancy? What are your concerns? And to listen to them, to what it is, and practice empathic listening, which is really, really important.
Great, thank you very much. Our next question is, how would you recommend to deal with a survivor who chooses not to vaccinate, but insists on attending a socialization program where the venue requires proof of vaccination?
Oof.
This is to all panelists.
You know, that's a really tough one. It really is a tough one, but what I would suggest, and again, if we look at empowerment and choice and control, perhaps that needs to be a group decision rather than the worker making the decision. Perhaps it needs to be a group decision, the people who are attending it. And are there other precautions that that individual can take, like social distancing, wearing a mask, for example? That would be my recommendation.
Yeah, and I just to kind of add to that too is part of the empowerment aspect of the choice is the understanding that all of our choices have both benefits and consequences.
Yeah.
All of our choices do. And to kind of allow that to be true for the person that's making this specific choice, that there are these both benefits that they are seeing and perceiving, and also these consequences that will also exist, and finding ways to work through that with them, or explore those, how much weight either of those hold with them, while still understanding that it is kind of ultimately their choice. And in many ways, I think, just to kind of give answer to that former question about being not informed about medical aspects, and the clients trust us and our opinions, is also to kind of, like Myra was saying, that the reframing, and also kind of remember to name that it will ultimately be their choice, and it gets to be their choice, right? It gets to be something that they can move through and think about for themselves.
Yeah.
I would like to just add one thing to that. I agree with all the responses. I think showing with the empowerment, the respect for their decision, not being dismissive or to question them as if it's unfounded what their thought process was, but to really see if you can actively listen to what the underlying concerns are, what their body language is saying to you, what their hand gestures, of the level of attention by which they're speaking with you about this, but really to figure out really what are their underlying concerns and see if those can be addressed. Sometimes it's not anything that they're saying. Sometimes it is something that can't be articulated, but if you can respond to them about concern for they may be uncertain about something, or have some deep questions about the process, and just respect their level of hesitancy on that, and figure out how you can help them where they are at that present time, and how they can move forward if they feel comfortable in moving forward, but always respecting that is their opinion, however they came to it, and making sure they understand that you respect that they have an opinion and a stance on that.
Yeah, I'd like to just pick up on that. What you're saying is so important, Arlene, because I was surprised to hear that some of the hesitancy was related to an actual fear of needles. That was the underlying fear that came out. It wasn't so much, the vaccine and the substances within the vaccine, but it was a fear of needles. So that's along the lines of what you're suggesting, to see what's really going on and to have a conversation. Yeah.
Thank you all so much for your answers. Piggybacking off of that, we have another question. And this question reads, there have been some activities that require proof of vaccination to participate. How can being excluded from those activities or sites because of their decision not to be vaccinated impact the traumatized individual further? And what can we do to support them through that rejection? I am also typing that into the chat box. 1 second.
I'd like to take this question. It's a tough one.
I'll take a stab at it. I think, one of the most recent ones I've encountered has been a book club I belong to, in which, at least one or two individuals have determined they are not getting the vaccine. So we've been meeting online, and this person has a very staunch opinion about why they prefer not to be vaccinated. So part of what the group has done is to accommodate that need, and to do a hybrid, to respect their opinion. So we have maintained our online capability, but going forward, there's going to be discussions of, social distancing within the meeting, those kinds of precautions, maintaining a mask, it's going to be a case-by-case decision. Some are more fraught with a decision, traumatic decisions such as a wedding. How do you protect everybody at the wedding if there's individuals who are not vaccinated? So I think it's going to be it's a delicate process, one that's going to have to have a lot of negotiation and consideration for everyone who's attending to make those decisions. But I think those are the issues we're going to have going forward, especially with the Delta strain, doubling in caseload now going forward. So it's going to be an ongoing issue.
Yeah.
Great, thank you so much. There are any other outreach strategies for these communities for the mobile vaccine operations?
I can try to answer this question. I think that when doing mobile outreach, it's really important to think about the communities that we are providing the outreach to. And like in some of the examples I provided in my presentation, oftentimes people feel like guinea pigs. And so making sure that there's a trusted relationship with community organizations serving that community and a partnership in hosting that mobile vaccine site. And it requires a lot of prep work. So establishing that relationship, maybe a week or two in advance and doing that outreach work, offering community health workers to go out and notify people about the vaccine mobile unit, right? Because sometimes if somebody's not from the community and they go and they have this mobile vaccine site, no one's going to show up, or they don't trust it. They don't know the people offering the vaccine, or they simply might just offer the vaccine at the very wrong time of day for the community. Maybe everybody's at work or at church or something, right? And so having this partnership with the community that's trusted, and that starts with just building those relationships. And I would recommend that, if this is the start of that partnership and relationship, that it also continue beyond the mobile vaccine units, and that your organizations kind of establish these trusting relationships with community-based organizations serving these diverse communities as like part of your long-term strategy.
Thank you, Shannon. I'm so glad we have a nurse, a public health expert, and social workers on this call to answer these hard questions. So we're going to move on now, and I encourage you, if you have questions, we'll give you an email to send us questions to, and we can always follow up with you, and we're happy to forward your questions to our expert speakers as well. So for those of you who are in the JFNA cohort who are subgrantees, the secret word is hesitancy, so you can prove participation. Next slide, please. So we encourage you to check out JFNA's Center on Aging and Trauma website for more information about the intersection of trauma and aging at agingandtrauma.org. Also, we encourage you to strategize how you will make your office and service more person-centered and trauma-informed. We have another webinar coming up later this summer, and it's going to be on the intersection of dementia in older adults with a history of trauma and also their family caregivers. So stay tuned for information about that. And again, if you have questions that we didn't have time to get to on this call, please write aging@jewishfederations.org. Federations is plural. And so we'd love to hear from you. And also we will make sure that your speakers receive the questions that they may be better suited to answer than we are. So with that, I'd like to really thank the speakers who presented today for your time and expertise. You really helped to make this a really rich conversation. And thank you to all the participants for joining today. And we look forward to working with you in the future. Take care.
Bye, everybody.
Thank you.